Hey everyone, and good afternoon or good morning, whatever your time zone happens to be. And welcome to today's webinar, which is Medicaid Options for Criminal Legal System Involved Reentry Support, offered by the National Association of State Head Injury Administrators. We really appreciate you joining us. I'm Maria Crowley with NASHIA. I'm going to be your moderator for today's webinar. Closed captioning, as you may already know, is available, and you can enable that at the bottom of your viewing window. If you need any assistance at all for today's webinar, just send us a chat. Questions for the presenters can also be added to the chat and will be addressed as we go or at the end of the webinar. If you're not familiar with our organization, NASHIA is a nonprofit which is created to empower state governments and their partners to enhance collaboration and strengthen capabilities to address the needs of individuals with brain injuries and their support systems. And in addition to numerous training opportunities such as this, NASHIA offers technical assistance and consulting services, and we provide support on a range of topics and on a range of things. And now, without further ado, I would like to turn things over to our presenters for today's webinar and other members of our NASHIA team. Zeta Ricker, who is our Director for Strategic Partnerships and Policy, and Judy Detmer, who's our Director for Technical Assistance. And Zeta?
Hi, everyone. It is so nice to be with you today, and I'm grateful for the opportunity to be able to talk about these opportunities and really to be able to hear from many of you about what you're hoping to accomplish in this space and how we can help to support that as well. And so with that, I will turn it over to Judy to introduce herself and kick things off for us today.
Great. Hi, everybody. Thanks for being with us. Really excited to talk about this topic. I'm Judy Detmer, Director for Technical Assistance and Special Projects at NASHIA. And we'll be running through some of the work that might be good for you to think about related to reentry and brain injury with some of the new Medicaid guidelines that are coming out. So if we can go to the next slide. So we just introduced ourselves, but we also would like to hear a little bit from you. We want to talk about why supporting people with brain injury in the criminal legal system is an important thing to consider. Give you some historical background on Medicaid, especially as it relates to the criminal legal system. And then share some opportunities, as I mentioned, for youth and adults leaving that system, as well as thinking about how to build partnerships and ways that NASHIA can support you as you think about this work. Next slide. So enough about us. We would love to hear about you. If you don't mind, I know there's too many people to do personal introductions, but we would love if you could put in the chat your name, kind of what you're representing, who you're representing, and why you were drawn to come to this webinar. That would really help us. I'll give you a minute to do that so we can kind of see who's here. Great. Thank you for putting stuff in the chat. Good group. Quite the variety of states, so that's good to see. And a mix of professionals and people. That's great. All right. Well, let's go ahead to the next slide. I want to dive into why it matters. I know some of you have heard me present, you've heard some of us at NASHIA present about this, but it's worth reiterating in the context of this conversation. What we know is that there is a high prevalence of people with brain injury that are involved in the criminal legal system that need support. So if we think about this kind of on a meta-analysis level, in terms on average, around 65% of incarcerated individuals will have experienced a brain injury in the past. And that is just, again, on average. As we think about the varied systems that are engaged in the criminal legal system, from law enforcement to probation to courts to incarceration, those numbers tend to increase as people escalate up the criminal legal system. So you're going to see higher percentage rates for those who are actually incarcerated versus probation typically. The other thing that we see are there are particular populations that are more susceptible or vulnerable to brain injury. One of those being female offenders or women with brain injury in the criminal legal system. We have seen rates as high as 90% with that population. Another one to keep in mind are those with co-occurring conditions such as substance use or mental health. Those rates are much higher as well. This is not just an adult issue. We see the same with youth involved in the criminal legal system. Around 49% on average have had at least one brain injury. And again, when we start looking at probation, those numbers tend to be a little lower than when we see people who are actually in detention or detained. Those numbers are higher. Next slide. So why it's important to support people with brain injury in the criminal legal system. One thing that we know through research is that the recidivism rate is much higher for those with brain injury than those without brain injury, about double. So 69% for those with injury compared to 37% without brain injury. And obviously, when we talk about the criminal legal system, recidivism is the benchmark. We want to decrease recidivism across all the environments. So those are significantly high numbers. Part of the reason we see that when the criminal legal system screens for risk of reoffending, we see much higher risk for reoffending in our brain injury population compared to those without brain injury. People with brain injury have higher rates of felony conviction, and partly due to circumstances related to the brain injury, they have lower rates of successful probation completion, as in they are oftentimes failing their requirements of probation, often due to technical violations and other things that with support could be avoided. So these are some of the reasons why it's really important to be thinking about brain injury in this context. Next slide. So historically, when we think about Medicaid for incarcerated populations, the federal law prevents people from accessing Medicaid for paying for services when they're incarcerated, except in some cases for inpatient stays. The issue then becomes that we see people leaving the incarcerated setting without access to Medicaid, and there's often a wait time and a process for getting back into Medicaid and services. So it creates kind of a snowball effect of issues. The inmate exclusion was established in 1965, and thankfully is currently being re-examined at both the federal and state level, which has led to some of the recent changes to the exclusion. And the aim of this is to create a continuity of health, mental health, and substance use care to improve health and public safety as it relates to people who are incarcerated and re-entering into the community. With that, I'm going to turn it over to Seda.
Thank you, Judy. And we can go to the next slide. So as Judy shared, luckily there have been some really exciting changes at the federal level that have allowed for there to be some Medicaid coverage for folks while they're incarcerated. And so we wanted to talk through those opportunities and ways to ensure that people with brain injury could be considered as part of those. First, we're going to talk about youth, and then we'll move on to adults. So starting in January of next year, every single state will be required to use Medicaid to cover some limited services for incarcerated youth who are soon to be released. And when talking about youth, Medicaid beneficiaries will include anyone who's under the age of 21, or if you are a former foster youth under the age of 26. And it requires all states to provide screenings and diagnoses and service referrals for youth in 30 days before or shortly after release, and to provide case management in the 30 days before and at least 30 days following release. This new mandate applies to all state, local, and tribal facilities where youth are incarcerated. So prison, jails, juvenile justice, and youth corrections. And in addition to the requirement that all states are required to cover Medicaid in these circumstances, there's also some additional options for states to use Medicaid to cover comprehensive services for youth pending their disposition of charges. This is a really exciting opportunity, and there's new ways and opportunities for funding to do this work that we'll talk through, and guidance from the federal government about how to do this successfully. So if you can go to the next slide, please. So I just wanted to dig in for a moment on the screening and diagnostic services and what is required. So the guidance from CMS says that screening and diagnostic services include any screenings and diagnostic services which meet reasonable standards of medical and dental practice as determined by the state, or any type of screenings that are indicated as medically necessary. And what they mean by medically necessary is defined in the early and periodic screening, diagnostic, and treatment requirements, or EPSDT requirements, that I'm sure many of you are familiar with. Unfortunately, listing brain injury screening itself is not included in the EPSDT requirements, but there are a number of different recommendations of the types of screenings, including behavioral health screenings and other co-occurring screenings, along with screenings that the state might consider as additionally needed. So this does provide an opportunity for there to be some brain injury screening as part of the requirements under Medicaid before release. Next slide, please. The other required activity is targeted case management. And again, under Medicaid, that includes comprehensive assessment of individual needs that someone might need before release, a development of a specific person-centered care plan that is built upon that assessment, and then referral to other services or needed services as part of that targeted case management plan, and monitoring and follow-up activities. Targeted case management in this instance is meant to be able to assist youth in connecting with services and providers, including services for health-related social needs in the geographic area where the youth will be released after release from whatever setting that they're in. So these are the kind of required things that under this new opportunity, every state must do. Next slide, please. So every state right now is working to implement these plans, and CMS expects that states will have a plan in place to do this through a state internal operation plan. And that state operational plan is required to be in place no later than January of 2025. But it's not something that CMS is requiring for states to submit. So states might have various processes about what that looks like. There are a number of different things that are required as part of the state internal operational plan, like the processes to ensure that someone gets timely services, new or updated provider and processes or policies, how they're going to meet case management needs, what they plan to do for training, education, and outreach, and any other kind of operational activities. And these are just a few things. There's a number of other requirements of the state internal operational plan, but these are places where we a lot of opportunity to ensure that the processes meet the needs of people with brain injury, or that they're are policies in place that people with brain injury can meet, and those types of things. And next slide, please. In addition to the operational plans, states also do have to submit a state plan amendment with an effective date of no later than January 1st, 2025. And in most cases for Medicaid, a state must submit a state plan amendment by March 31st of next year, but it will have an effective date of January 1st of next year. And CMS right now is working to develop a state plan amendment template to help assist states in putting together their state plan amendment submissions. And this is something that the states will be required to actually submit to CMS, unlike their operational plans. Next slide, please. So what to do with this information? NASHIA has a couple of recommendations that we are hoping that partners can bring to their states to ensure that there is some support for people with brain injury. And later in our conversation, we will spend some time talking through how you can partner with your Medicaid agency or other partners to do this. But in particular, we would recommend that there be brain injury screening as one of the required screenings to help identify folks that might have a brain injury. And we do have the online brain injury screening and support system tool, OBIS, which maybe I'll have Judy explain in a minute as a potential option for states to include as the kind of required screening for brain injury. And then once you have identified that someone has a brain injury and might have some need some compensatory strategies to support them, to ensure that that targeted case management is done in a brain injury informed way, and that those case managers can, again, have someone with a brain injury identified, provide some specific compensatory strategies, and ensure that they are referred to appropriate services to help support them with their brain injury. So really quickly before we move on, Judy, do you mind jumping in and talking about OBIS and how it's being used in some of correction settings currently?
Yeah, I can definitely do that. Seda, there was also a question in the chat that I wanted to just point out now about targeted case management. Does that also apply to children on or using CHIP?
It does, yes.
Okay, I thought that was the case. I didn't want to respond without your input. Okay, so the online brain injury screening and support system is a tool that was developed at NASHIA in partnership with Dr. John Corrigan out of Ohio State University and MindSource, the brain injury program at the Department of Human Services in Colorado. It combines both a lifetime history screen for brain injury, and that's the Ohio State University Traumatic Brain Injury Identification Method. It's a long title, but OSU TBI ID, with a symptoms questionnaire that was developed by MindSource. The goal is to first identify, did they have a lifetime history of brain injury? If they do, based on this validated instrument, then they are prompted to take the symptoms questionnaire. Both are self-report. The symptoms questionnaire is designed to try to get an understanding of where the person feels they are currently having challenges. And it's across those hallmark symptoms of brain injury. So if you think about things like short-term memory loss, executive function, things like organization, impulse control, some of those things, those are the questions that are being asked. If they screen positive in one of those areas, they are provided with a tip sheet related to the area that addresses compensatory strategies. So when we think about those things, I just want to be sure to stress that these compensatory strategies are somewhat simple in nature. It's not treatment for brain injury. So if you think about short-term memory, it's an example could be ensure that the person sets reminders in their phone, ensure that the person writes down a summary of the note of the appointment that you had with next steps, or provide them with that. So it's simple things that we can do to compensate for the deficits related to the brain injury that will help them succeed. And OBIS just packages all those things together. So if you guys have more, I'll put in the chat a link to OBIS and you can look that up as well.
Thank you, Judy. And OBIS is being used in some corrections settings. And so again, I think we would really stress that we feel it's important that under these new requirements for Medicaid, that youth are screened for brain injury and that the targeted case management is brain injury informed. And I know we have a number of different folks on the line. I think as much partnership as possible that can happen within your state to come together to go to your Medicaid partners would be great. I see Department of Corrections folks on the line, and state brain injury leads and brain injury associations. And so I think really coming together as a group and making a case to your Medicaid partners about why this is so important would be a great step. And again, we'll talk about that in a little more detail in a little bit. Next slide, please. There is also a funding opportunity for state Medicaid agencies to support the goals for their youth activities. There is enough funding for all 50 states, but some states might decide they do not want to apply for funding for this. There is funding for 2 cohorts, and about half of the funding will be released. So funding for half of the states in the first cohort and the other half in the second cohort. And if a state applies for funding in the first group and does not receive it, they can apply for funding again within the second group. And the funding is used for, among, again, a long list of activities, identifying and addressing operational gaps with respect to complying with the requirements or adopting their state plans, and help ensure that they're collaborating with a number of these different agencies, which would include community-based organizations, providers, Medicaid managed care plans, and other federal agencies as well. So I think really there's an opportunity to ask your state if they plan to apply for this. If they aren't planning to apply for it, to really encourage them to do so, because there is enough for every state to receive funding should they like that. And it will really allow them to build strong plans and systems of support for the partnership, and then working with them to see if there are some opportunities for there to be brain injury supports written into the grant opportunity. Really, it would be for building capacity or building partnerships to help establish the requirements and the goals of the youth requirements. And next slide, please. So again, really encourage folks to work with their state Medicaid office to ensure that they're seeking funding, and include in the funding solicitation on a focus on addressing those service gaps for people with brain injury. And we can talk through the best way to do that. But as we mentioned, I think seeing all the various folks on the line, making sure that there's kind of a cohort or partnership of those who are focused on this issue within the state, going to Medicaid partners together to do this. Before we move on to our conversation about adults, do we have any specific questions or follow-up for the youth piece? I see a question about how would this affect an individual who has sustained their brain injury while incarcerated. So there are, most youth who are incarcerated and adults who are incarcerated are eligible for Medicaid. So really, these requirements will impact everyone who is criminal legal system involved, and there's an opportunity to help ensure that those who have a brain injury, whether they had it while they were incarcerated or not, are identified and supported appropriately. Are there any other questions, or Judy, do you have any other thoughts before we move on to the adult conversation?
Not seeing other questions in the chat, so definitely put those in there if you have them. I will just add to me the question that was asked about if they sustain their injury while incarcerated, really to me builds the argument for screening as people are leaving, because they will not have been diagnosed with a brain injury coming in, and that, you know, the medical history has already been gathered, all of that, so that will be missed. I will say too, just to another emphasis on screening, because a lot of people do not come into the criminal legal system with an actual diagnosed brain injury. It is screening that is really uncovering those injuries and getting people the supports they need. So regardless of this whole initiative, screening is a really critical piece, and I see people chiming in on that and appreciate that. But definitely to help them be eligible for these supports under Medicaid, it's critical.
Great point, Judy. Okay, next slide, please. Okay, so there are also opportunities for adults who are looking to receive support in their reentry through Medicaid. There are a number of states who have applied for a Medicaid 1115 demonstration waiver. And if a state is approved for this demonstration waiver, then starting up to 90 days pre-release, Medicaid can cover services for someone when they are incarcerated. And states must cover 3 services: targeted case management, again, medication assisted treatment, and a 30-day supply of prescription medication at release. CMS has approved 11 states, and 13 states have proposals pending at CMS. And this is a very popular demonstration program. We are hearing from more states that even more states will look to be approved, and will likely have more people apply for this and be approved. It's something that CMS is really prioritizing approvals for. Historically, you may have heard that 1115 demonstration waivers have very slow approval processes, and that is true, but there's been some recent push to really get these funded, approved, and so that's happening more consistently now. So I think we can go to our next slide, please. We would love to think through if there's an opportunity to engage with your individual states with you on the line. I know there's a few of you, but if you're a state where you know you have an approval and you'd love to learn more about it, or if you think that you'd love to get your state more engaged, if you don't mind just putting your state in the chat, and we'll pick a couple to dig in on, and I'll show you a really great resource where you can look into your state and learn more. Awesome. Okay. I'm going to pull up this resource and we can look through a couple of these states together. Okay, I'm going to share my screen here. Okay, can everyone see this? Okay, so the Kaiser Family Foundation has a great tracking system of all 1115 waivers, and that includes the reentry waivers and any other waiver that CMS has put out. And so I will just focus on the justice involved waivers currently. And I saw a number of different states in the chat. Judy, are there 1 or 2 that you think I should?
I just saw Massachusetts come through.
Okay, perfect. Well, I do know Massachusetts has been approved, so we can use that as an example. So Massachusetts has been approved for their 1115 waiver, and they're focused on incarcerated individuals in state prisons, county jails, or youth correctional facilities with 90 days before release. Their focus is on providing a limited package of reentry services, which includes those 3 things that are required under the 1115s, and some other benefits like physical and behavioral health consultation services, medications that are phased in over the course of the demonstration. So this website, I do feel like, does a nice job of giving a very high level overview of the types of things that are included. And then what I would recommend that you do if you'd like to learn more from your state is to search Mass Health approved 1115 waiver or justice waiver, and really dig in and read their approved waiver. And that will give you a lot more details on the types of things that are covered and give you some ideas that you might want to take to your state Medicaid partners as they think about as you think about what they might be able to do. And again, I think in particular for this, what we've seen as the biggest opportunity is some case management done in a really brain injury informed way, in particular with the 1115 waiver approvals. Is there another state maybe we can look at?
I'm wondering, I see a lot of representation from Colorado.
Yeah.
Whoop, whoop, go Colorado. That's where I'm sitting. Appreciate all you here. I was wondering about Colorado, but they're not approved yet, but it'd be good to talk a little bit about the opportunity even there.
Yes, so even if a state is pending their submission, so Colorado has submitted an application and they're pending it. And they are focused on state prisons or juvenile facilities, and they're really focused on the required opportunity on their 1115, so case management, MAT, and counseling, and a 30-day supply of medications. You can similarly look up if a state has a pending application and what the details are of that pending application, and really dig in to see if there are opportunities. And I would reach out even before the application is approved, because again, CMS is trying to go through the applications as much as possible and as quickly as possible so that you'll be prepared to be in a position to support the approval once it is approved and ensure that brain injury is at the table even earlier in the process. In some ways, if your state isn't approved yet and is pending, it's a good time to get in front of them and ensure that you're part of the plans. The other thing I should say is that these are 5-year demonstrations, so there's an opportunity, even if they're approved and they're working on it within their first year, to still get involved. And there's only a few states that have really dug in and doing the work so far. A lot of these states are still very early on in their planning processes of the demonstration waivers. And again, even if your state has not applied, they might be. So again, would recommend that you reach out to your Medicaid partners and see if it's something that they plan to apply for or submit eventually, because we know more states are focused on this.
Zeta, you got a question in the chat about scrolling down that list to show all the states, or just drop that link in the chat if you would.
Yeah, absolutely.
I've got the link I'll drop in there. The other thing, Zeta, I don't know if you have this link handy, but for the funding opportunity, if there's a way to share that link.
Oh yeah, yep, I can send that.
Did I just blow up the chat with putting that link in there?
Possibly.
Okay.
No, just kidding.
My chat looks funny now that I put the link in, so I asked that question. All right. Okay.
Okay, I think that we can move on to the next slide, which I think I'm turning over to Judy to dig in on more. And while Judy's talking, I will put in the link for the CMS funding opportunity.
You can go one more. Whoops. Wrong way.
No, it actually this is this way. I think I just already talked about it. We're
Oh,
good.
got you. Okay.
Next slide.
Okay, so there are some resources and some agencies available to help you think through some of this work. I'm going to start with the resource on the right, and we can also put this in the chat, but NASHIA worked with the council and state governments and many other subject matter experts across the country to respond to the Bureau of Justice Assistance task with understanding how to best support people with brain injury in the criminal legal system. And so what the council and state governments did is held key informant interviews, they had focus groups, they did a lit review, they just did a lot of work to try to understand what are the best practices as it relates to building a justice system that's inclusive and responsive to brain injury. So when you go in and look at that report, you'll find helpful tools suggested that you can use as you think about a successful way to interact with your Department of Medicaid in terms of how to support people through this reentry work. They include screening, training, support the compensatory strategies that we talked about, and then community referral. So that will be a really helpful resource to you as you kind of work through thinking about how to connect with your Department of Medicaid and come up with an idea about how to support folks. The other is the HARP program. So that's the Health and Reentry Program, HARP. They have this report, which is 8 key considerations for successful implementation of new Medicaid reentry policies. It's another one to take a look at. But just in general, they are a wealth of information as it relates to technical assistance for reentry, and this issue particularly. So, you know, you can always reach out to them as well. Next slide. Okay, so is there anybody on this call from a state Medicaid agency? If you wrote it in the chat or put your hand up or however you want to identify yourself. But one thing that is critical here is that people connect with your, oh, good, Patrick, thank you. Chime in if you have anything to offer here. But what we're encouraging people to do is connect with their state Medicaid agency. We heard at our annual conference from Kate McAvoy, who is the director for the National Association of Medicaid Directors. And she just encouraged that we should feel empowered to reach out. Medicaid agencies are also trying to understand how to best support these populations. So reaching out and providing your lens of expertise will be helpful to them. In addition, just to ensure that you're advocating on behalf of people with brain injury. A good place to start is with relationships you might already have. It's hard to know exactly the right person to go to at Medicaid, but if you have someone you've been partnering with in your Medicaid agency on other issues, that's a great place to start, and they can help guide you to the right person for this issue. If you don't have a relationship, you can find your Medicaid office contact info at the link that you'll be getting these slides, by the way, but at the link at the National Association of Medicaid Directors website, you can find who your contact person is in your state. The main thing is to reach out to them and provide them with information on the data and come prepared with an ask. So you want to be thinking through before you have that first meeting with them, what are you asking them to do, and what's the justification for the ask? And so we have a lot of data out there about justice involved individuals with brain injury and this intersection. If you're struggling to find some of that information, you can always reach out to us, but also know that that Minds Matter report that I mentioned just a moment ago, that the BJA did, has a bunch of that data in it. So you can use that to frame your argument, but also then to say, here's the solution. And again, as Zeta mentioned earlier, you know, we suggest you're talking about implementing screening for brain injury, providing training and education so that the case managers are brain injury informed, helping them think through what are the community resources and supports that could help this individual. And then the other thing to know is that we're here for you. So NASHIA can help support these initial conversations. So if you're just at a loss, or if you feel like you need that backup support, that's what we're here to do. So you can feel free to reach out to us. We can help you think through kind of how to frame the argument. We could also help you just with some of those initial conversations. Next slide. Oh, before I go on, I saw that Sarah, also from Colorado, is here from the Medicaid agency. And Patrick already mentioned that. So if you guys have any other additional thoughts for how people can get connected to their Medicaid agencies, or anything you want to add, you know, your perspective would be really valued. So if you want to put that in the chat, or if you feel free to come off mute if you have something you want to add, but please feel free to jump in. Thank you for being here. So I mentioned that NASHIA is here for you. So some of the things that NASHIA can do to support you, we mentioned the online brain injury screening and support system. So that is a tool that it's validated, has evidence-based practices in terms of compensatory strategies. It's already ready-made, something that could be implemented as part of this work to be the screening tool that's used. So that's one area. We'll talk, I think we have a slide, right, Zeta, about Leading Practices Academy. So I'm going to hold on that, but we'll talk about that in a minute. We also do a lot of training. And so we're happy to provide training for your systems if that would be helpful to highlight the issues related to this intersection. We work a lot with systems capacity. So thinking through how would something be implemented, partnerships, how to connect with certain partners. So we do have a really diverse crowd here today, which is awesome to see. So if you're working like in a Department of Corrections and you don't know who's doing work in brain injury in your state, please reach out to us. We'll get you connected. Vice versa, we can help you if you're in brain injury to think about who you should be connecting with in terms of a justice staff. So definitely reach out if you want to make some of those connections. We also provide technical assistance. So we're definitely happy to help you frame some of this if that is something that you would like support with. And then it's Zeta mentioned that funding opportunity. I'll throw out there that oftentimes we've been working with states to help assist in grant applications and to be project managers for some of those grants. So we know that capacity can be very limited with states. And so if you're feeling intimidated by that, that's something that NASHIA could potentially help out with as well. So again, we just encourage you to reach out and we can kind of think through any supports that you might need. Next slide. Okay. Zeta, do we want to jump into our questions? I know you have a list of questions, but maybe before we go into those, if anybody has questions that they haven't asked already in the chat, or if there's some thoughts that people want to share, now would be a great time to do that.
Is it okay to come off mute and ask a
Yeah.
question?
Go for it.
Great. So I'm from North Carolina, and Medicaid expansion is recent to our state. So we're already kind of like, that's a new endeavor. That's pretty big and it's going well. And I come from the overdose prevention space. So there's a lot of advocacy to try to get people leaving carceral settings connected with Medicaid, particularly so that they can get Medicaid MAT for opioid use disorder, because they're at such a high risk of overdose death in the first couple of weeks of, as you know, of reentry. But I guess what I'm wondering is, do y'all support, since I'm coming from a public health space, not from the carceral, state prisons, and one of the things that we're dealing with is like how to support the prison in streamlining their paperwork for this, because that's really challenging for their staffing and just capacity capacity around like how their systems operate. So is that something that you know of resources, or that is that kind of like involved in your technical assistance?
I'm gonna let you jump in on that one.
I know that there are a number of conversations that are happening among our organization, some of the other sister associations, because it is not a challenge that's unique. Where I know NAMD and some of our other sister association partners are hearing very similar things as states are looking to implement this. And so it is a focus of our collective organizations to develop some resources to support that and can keep you top of mind as we do that, and make sure that those are sent your way. I think we're still thinking through the best ways to provide technical assistance, and so definitely would encourage you to reach out and we can think through if there's opportunities for us to support that. I think in some ways we have, we're a little bit further ahead than Medicaid typically is in some agencies in supporting the reentry work already, just not always connected to Medicaid. And so we might have some best practices from our other work outside of this that we could share as well.
I also would like to add, because we do have a reentry program in a detention center here in Lincoln County of Nebraska, and it's called Strengthening Purposes for Inmates. And our problem is we can get them the Medicaid right as soon as they walk out the facility. And there are a few that if they're diagnosed ahead that have Medicaid prior to being incarcerated, there are a few that can keep their Medicaid. But my concern is we have recently had some of those like physical therapy and some of the out of the box type Medicaid treatments that were once paid by Medicaid now dropping off so that Medicaid won't take Medicaid. So is there a solution for that? Because that's my biggest concern. We get them this Medicaid and then Medicaid doesn't cover the treatment or what they need, what their needs are. So that's my question. Is there an answer for that?
That's a good question if there's an answer for it. I don't know, Zeta, what your thoughts are, but it seems like what's covered by Medicaid is determined largely at a state level, and looking at your state plan Medicaid. So doing advocacy at that level to get that inclusion, I think would be critical. But Zeta, what's your thoughts?
Yeah, I agree. I think that's very state by state based and is kind of separate from the reentry conversation opportunities. I think because I think you are further ahead in being able to get folks connected to Medicaid quickly. The bigger challenge across the nation is that reach in is really needed to ensure that they even can get Medicaid coverage, which is why these opportunities are starting to exist. So you're just probably further down the line, and we'll start getting more of those questions later.
Okay. I do know the one thing that we've started doing is a lot of fundraising. So we have some dollar amounts that can help pay for some of those copays. And I do know that our chiropractors and our physical therapists are working with like giving us a below cut rate, I should say. They don't charge us as much. So for our inmates, but yeah, I just was wondering about that. So thank you for that input. I appreciate it.
Yeah, and sure, one other resource that you might look into, I'm going to forget the name of this, and I'm hoping Maria can jump in, but it was first started, I believe, in Georgia, and it is a group of folks who are doing what you're saying, like they're trying to pull together, they have a nonprofit that provides reduced costs or fee for service, physical therapy, occupational therapy, speech therapy, durable medical equipment, where people are not qualifying for those supports through either Medicaid or insurance. I want to say it's RSVP, but I don't know.
Let me look that up for you while we're.
Okay, we'll get back to you on that.
Thank you. Thank you.
And then Patrick, I see you have your hand up.
So I'm Patrick. I'm with the New York State Medicaid program. One of the things that I think we're a step ahead of the game on is we have been working across the whole state for the last couple of months on gathering experts around the table. just getting perspectives and understanding what we're looking at and what we're dealing with. We don't really have a very accurate depiction of what brain injury looks like within our state. We have a TBI waiver, but that's for a very specific set of folks. So, one of the things that we wanted to do is we want to understand who's out there and where they are. So we're working on defining TBI through using Medicaid data. That's in its early stages, but I think that that'll help us understand. And then we're also just working on understanding what resources are out there and getting everybody on the same page. So we've been having care innovations conversations. We've had our first of 4. And those will continue through to the end of the year. And I think that helps really level set with what is going on in the state and what needs to be done to further care for people with brain injury.
Yeah, that's great. I love what you guys are doing. We'll put in the chat, we have a state directory of services and supports in each state. So you can see kind of who's in New York. And if you haven't already reached out to them, might be additional people to reach out to and think about what resources are out there. Generally speaking, it'd be the lead state agency on brain injury, which can sit in a variety of departments. That's why I'll put the link in the chat. Actually, Maria already did. And then the brain injury associations or advocacy organizations are a good one to reach out to as well. So that would be my recommendation in terms of thinking through who those supports and resources could be.
We work really closely with our Brain Injury Association of New York. Their members is on call. So, we're really grateful for all of the partnership that we've found through this initiative. So thank you for this training. It's really wonderful. It's great information.
Thank you, Patrick. Appreciate it. All right, Seda, do we want to go on to the next slide?
Yeah, I think we just have a few questions that we'd love to pose to the group to help to think through what you might want to do as next steps in this conversation. I know we only have a few minutes left, so we'll just share all of the questions at once, and anyone can feel free to chime in again through the chat or unmute yourself or raise your hand. I'm curious if any states have had any conversations with your Medicaid partners on these efforts in particular, or on other efforts that you think there's a really easy connect to be able to move this forward. What are some of the pressing needs in your state related to reentry, and are there some ways that you think these opportunities could be leveraged to support those activities? What maybe are some barriers that you're facing from your Medicaid office or other partners as you're broaching these or other similar topics? How can NASHIA help? Again, and in the last few minutes, I think we just love, it's really helpful for states to hear from one another about the various ideas that they have or how they're approaching things, or ways that we can help to support you to do more in this space. So would love the group's thoughts.
I'm seeing the one around having issues with placing patients in rehab settings that have severe behavior problems. Unfortunately, Lisa, that is a problem we see across the country, but if you reach out to us, we might be able to help guide you in your particular state. There are providers out there that do neurobehavioral care and support for people with brain injury in different parts of the country. So that's something to consider. Other things that we think about with behavior problems is what's the root of that behavior problem? And could there be some interventions like behavioral, like CBT or therapeutic interventions that are not commonly thought of with behavior, but when we think about what's causing that behavior with brain injury, it could be that they're overloaded, overwhelmed, overstimulated, so many different things that could be maybe addressed through the environment and with some kind of mindfulness and different kind of strategies. So that's a tough one to answer, but happy to connect offline a little bit more specifically.
Yes. Oh, I'm sorry. I just took myself off mute. Yes.
That's
So we
good.
met with neurorestorative.
Okay.
And, So I think there's like a lack of behaviorists that can actually maybe try to use some kind of medications to manage patients. And then of course, patients seem to get worse in a hospital setting because they're not stimulated or they're bored or they've been like restrained
Yeah.
to their room and then their behaviors get worse. So there's all kinds of factors, which just I feel like we're making people worse instead of better in some way.
Yeah, I hear you. That definitely it's a tough issue. And I think that the environment is a key when we're talking about that kind of behavior management.
Yep. Thank you.
Hmm. Okay.
I see one comment from Patty about the lack of available providers and services, which I know we just talked about. Very similar challenges from Lisa, but I think the other thing I would share is since these opportunities do have such a focus on screening, that is, if utilizing OVIS or other similar tools, a way to get things started. And I know oftentimes with screening, we think screening now what, but I think with some of the screening systems out there like OVIS, that does give a little bit of the now what. It provides some of those compensatory strategies, and it's just that first step. So I would say even in those places where we don't have the infrastructure yet for those connections to services, we can help you think through how to develop those infrastructure or what is already out there, and really to prioritize that screening as a first step. Thank you all so much for joining. I know we wanted to spend a couple minutes talking about our LPA to wrap things up, so I'll turn that over to Judy to do that.
Great, thank you. So a lot of you maybe are familiar with the Leading Practices Academy that we have led at NASHIA now for several years. We had focused on criminal legal system and behavioral health. We are continuing to provide this Leading Practices Academy, but in a kind of slightly different format this next round. So it's a Leading Practices Academy on social determinants of health and brain injury. It'll start in January. We'll have these different spokes, one being the criminal legal system. So if you are interested in some really specific technical assistance related to this, that could be an avenue to get that from us at NASHIA. Housing insecurity is another spoke. Child welfare and intimate partner violence is the other spoke. So if you go to the next slide. So in terms of who can apply, there is a tuition for this. It's a $10,000 tuition for the year. We can definitely talk with you about creative ways of thinking about funding for this opportunity too, as we know that can be a lift for people, but we've had some great success with states finding creative ways to get funded. Who can apply? Really, any one of you on this call can apply to be the lead for this effort in your state. And again, around those 4 issues. What we provide is we provide customized technical assistance with subject matter experts across those issues. We have monthly organizational meetings with your state, both with you as a leader, if you were to be the lead of your state, and then with a fuller team of partners that we will help you identify. We have academy sessions with all the states that will be in the LPA. Zeta said this earlier, but we find that states learn a lot from each other when we just allow you all to get a chance to talk to each other. So that's one of the opportunities through the Leading Practices Academy. We develop a spot for centralized resources, and then we have a summit that ends the year. So if you were interested in this, and if you want to be the lead, you would be the lead staff to manage a project in your state, recruit partners, but that's something that we at NASHIA would help you identify who those partners could be and help you engage them. We would help you develop a work plan, and then you would be ensuring that those plan activities are accomplished. So if you want more information on that, you can email us for sure. And if you know you're interested, that QR code that's down there is a jot form to an application to be part of the Leading Practices Academy. That is due the beginning of December. So just time sensitive, just heads up on that. But again, reach out to us if you have any questions. And I think we are at the hour. So with that, Seda, you want to wrap?
Yeah, thank you all so much for joining us. We really appreciate it. And Judy and I will put our emails in the chat quickly. So if you have any follow-up questions, feel free to reach out and we'd love to continue to be partners here. Thank you.
Thank you.